Dear colleagues, Assalamu alaikum. Welcome back and happy Eid. We are once again back on our weekly webinar series. Today we had a talk on future of endoscopy or GI endoscopy in future. And Dr. Nag Reddy was supposed to enlighten us on the uh, futuristic trends in the GI endoscopy. Unfortunately, because of the COVID situation, he was called by his chief minister, and he's on his way for his official meeting. He has sent his regrets. So we'll unfortunately have to reschedule this talk. But for now, I'm sure you'll be having lots of burning questions on ERCP in US. We have a panel of expert here. Dr. Khalid Hassan is here. Nadeem is here. John Leeds is here. And I, myself and Saad, we are available. Please feel free to ask. Otherwise, we'll have to reschedule today's meeting on some other day. If you have any question, please feel free. Uh, unmute yourself. Um, and Dr. Atta Said wants to say something. Dr. Atta, please unmute yourself or write your question.
And the series that you're conducting, I think, is probably the best in the world to learn um, for those who are learning as trainees, but also for people who are in practice, especially in the lower volume centers. So I'm just wondering if I could ask a few questions which are quite common, maybe from Khalid, but also from other experts, including Rayaz, Saad, and John. So Khalid, you did an excellent presentation. Actually, you did two. One was on cannulation, another was on a difficult cannulation. Both of them are outstanding, and I think are great learning points. So there were two particular kind of ampullas, Khalid, that you mentioned. One was a floppy cannula, and how do you get around the problem? Because when you try and cannulate, it can go to one side or the other side. And the second one, which you explained very well, was the up and over kind of ampulla, where you have to do certain maneuvers for a successful cannulation. I wonder if you could go over those two situations, followed by I wonder if I can ask Rayas. I think he has done a presentation for the ASGE on pre-cut, uh, and if he can give us any tips regarding needle knife pre-cut in difficult cannulation.
Gyasbhai, can you just answer your question first, and let me see if I can pull up my presentation quickly and I can go over that.
I think the salient points on the pre-cut in the deep cannulation was that, first of all, it is best to avoid. But if it is absolutely essential to do the pre-cut, then one has to remember the anatomy of the ampulla. And it has to be done in a systematic step-by-step fashion. And it is never ever that one should take out the needle knife in its full length and start cutting from the bottom to the top or from the top to the bottom. Either way, it has to be a very stepwise calculated cut, and small cuts are better as compared to one long cut. And important thing is that one needs to try identifying the yellowness of the biliary fluid coming out of the lower end of the biliary sphincter. So the target is obviously either the pancreatic sphincter or the biliary sphincter. And one has to remove the hood, removing the mucosa, removing the submucosa, and getting up to the point where one is able to see the two openings. Although I understand that when we are cutting, there's some amount of blood ooze as well. But by squirting the fluid from the tip of the cannula, we can clear out the field and we can see the openings clearly. So three important things. Number one, cutting in a stepwise fashion. Number two, cutting according to the anatomy of the ampulla. And thirdly, remembering the anatomy of the ampulla. These are the three important things in the pre-cut.
Do you prefer, Rayas, to cut in the middle like a fistulotomy, or do you start at the ampullary orifice?
It really depends on the appearance of the ampulla. At times with a bulging ampulla, I start from the top. And with a flat type ampulla, I put the needle in the orifice which is available and pull up the tip of the wire towards the endoscope and cut it to the proximal side. So it really depends on the type of the ampulla that I see. For
Riaz,
bulging
can I?
ampulla from top to the bottom, yes, please.
No, continue. I just wanted to add something. You finish first.
For the bulging ampulla, I shall prefer cutting from top to the bottom, and for the flat top ampulla, from bottom to the top.
Can I just add a few things here?
Sorry, sir, just one supplementary question. Do you prefer having a pancreatic stent in Riaz before you start the pre-cut, or it doesn't matter too much?
Once I've put the wire into the pancreatic duct, it is rarely ever that I need a pre-cut, because once the wire is there in the pancreatic duct, then the ampulla is straight. Then with the positioning of the tip of the papillotome, management of the guide wire, invariably we are able to get into the CVD. And most of the time I use the double wire technique. I don't cut through the pancreatic sphincter. And once my guide wire is there in the pancreatic duct, in that case I don't go for the needle knife papillotomy. In that case, I always go with the second wire.
And do you put a pancreatic stent in afterward?
Yes. Once the wire has been placed in the pancreatic duct and it has stayed there for some period of time, although it's very difficult, but once it is gone in, my natural reflex is to put in a stent over there.
That's excellent. Thank you, Saad. You were going to say something.
Yeah, I was just going to add a few things here. Firstly, I think it's important to understand that we all need to understand that we have good cannulation success rate before we embark upon doing needle knife. So if your cannulation success rate is not what is expected or recommended, then I think we need to improve on our cannulation. Like Riaz just said, you use double wire technique or you whatever methods you want to using sphincterotomes. But ideally, we should be able to cannulate in almost 90% at least. In my opinion, 90% cases should be cannulated straight. If you're going to do needle knife, again, it's very important. If you don't have a steady hand, your needle knife will be zigzag, and that's not the time. That means you're not really ready to do it. And I've seen it many times, and we've all seen people doing needle knife, because what happens is, if you haven't done the right needle knife or you haven't cut the right thing, then when the patient comes back to Riaz or Khalid or John, it becomes very difficult after it has been messed up sometimes to actually to cannulate. So it should be done properly, whether you do it from top or bottom. I usually use I don't use fistulotomy, almost very rare, except for when I see a stone or a very bulky. I go from down upwards. Again, like Riaz said, stenting, pancreatic stent is always useful. If you can do it, it's always better to do it if you're going to do needle knife. But one point which I think is important is, if you can't get needle knife, you don't have to try too hard to get in on the same time. If you're not getting in, leave it, come back after 4 or 5 days, and you will see, quite often you'll see it very clearly. So although you may see in the workshops and all, Khalid coming and doing it and making it look very simple, but trust me, if you come back after a few days, it looks very easy, and you can literally quite often see the bile coming out, and it becomes very simple, rather than making it into a mess or continuously going deeper. And the last thing I think is very important to make sure that depending on what diathermy you're using, that you don't use too much of coagulation with it, because that's again going to be not very helpful for you. So, and one thing that I was taught which sometimes works is, even after needle knife, I always try going back from where the actual opening was initially, just a slight attempt. Sometimes it's very interesting, you get into the damn thing very quickly. Otherwise, if you see the opening, then you just go in wherever you can see the bile duct. So those are the few things that I wanted to add. Over to you, Riaz.
Can I add something as well there?
Yeah, John.
Yeah, I think the first thing to say before you even embark on the needle knife is to look at the case and why you're trying to get access. So, if there's someone who's deeply jaundiced or someone who's got severe cholangitis, then you want to do everything you can to access. If there's someone just with a symptomatic stone, then you've got to think, well, is this the right thing to do? Is it worth just coming back another time, another list, another person, another centre, whatever it is that might improve the chances of getting in without using a needle knife? I think what we've had in the past, certainly in the UK, is people using a needle knife right at the end. So they've tried for half an hour, 45 minutes to get in, and then finally use a needle knife. And at which point the risk of pancreatitis is already really high. So if you're going to work your way to it, you should get to it relatively quickly. But as I say before, I think it's about trying to be sensible about which cases you definitely go for it in. And as I said absolutely correctly, I think what you sometimes find, I always think it's a bit like, when sometimes you can't get the lid off a jar, and you've had someone else try it for a bit, and then you hand it to someone else and they seem to manage. A needle knife can sometimes be a bit like that. So, your trainees try to get in, they maybe do the needle knife, then you take over, but actually you get straight in. It's because it's somehow loosened up that bit of fibrosis or whatever it was just there. So, don't be afraid, as you said. I completely agree with that. Once you've done the needle knife, you're not getting in through where you've cut. Kind of go back to the first principles, because actually it may be that you've loosened something somehow. And we also do, if you fail, you've done a needle knife, you bring it back 3 days later and have a go, and you just get straight in. It's again, you've had a bit of local ulceration or necrosis, and it just shows you the way in. So don't be afraid to
yeah, that's very useful. John, your acoustics are a bit crackly. I hope they can be fixed maybe for the next question. Khalid, do you have your slides up?
Can you guys see my slides?
Yes, I can.
Okay. So thank you, Atabhai, and thank you for all your comments. With regard to needle knife, I totally agree with all the comments. One thing is, like, as Sadbhai said, that don't embark on needle knife from right away. In the conferences, these live cases, you see this all the time. There may be 3 cases of ERCP being presented, and 2 end up doing a needle knife. That is not the right, that's not the appropriate, really, proportion of use of needle knife. Needle knife should be used really when your success rate, actual freehand cannulation, selective cannulation success rate is 85 to 90%, and rest of the 10 to 15%, I think it's appropriate to use a needle knife, bringing your success rate more than 95 to 98%, some in that range. So at that point, and when you use the needle knife, I prefer personally, if I can get a pancreatic stent in, I like to do over that, just for many reasons. In a case, if I have to stop the procedure because patient is unstable, bleeding starts, or something happens that you have to abort the procedure, at least pancreas is protected in that case. Having said that, I've done a needle knife without pancreatic stent as well. Other thing with regard to needle knife is, it's not a superficial cut. It's not a mucosal cut you are trying to do with the needle knife. If you're doing a needle knife, if you just cut, let's suppose here, just the superficial area right here, that's never going to take you into the orifice. So you have to cut deep. You have to cut the sphincter muscle to really get to the orifice itself. And also, before you do the needle knife, always what I personally do, or the way I teach my fellows, is I don't just tell them, get the knife out and then start cutting. What I do is I ask them, get the knife out and tell me what is your direction of cut. Where are you going to start? Which direction are you going to go, and move the needle up and down in that direction? For me, obviously, we need to know whenever we do the cannulation where the orifice is. But for me, equally important is where the papilla is meeting duodenal wall. Here, this is the orifice, this is papilla. I'm looking at this fold, I'm looking at this fold, I'm looking at this fold, and then I see that's where the duodenal wall is. So I have this imaginary line, which I draw from the orifice all the way to the wall. And that would be my direction of cannulation. That would be my axis of cannulation. And if I have to use the needle knife, that would be my cut or line of cutting that ampulla itself. So it is always whenever the way I tell, and I personally do pretty much every single case, I study the papilla. For me, it is very important. I cannot stress that enough, that it's very important for me, not only where the obviously orifice is, where the papilla meets the duodenal wall. And if it's a flat papilla, becomes very easy, even though that may be a little smaller papilla, but that is very easy to cannulate. The problem happens with the floppy cannulas, and I'll go a little bit over that in a few minutes. And the reason one of the examples I give is when you're in a cecum, you look at the appendiceal orifice, you see at the curve of the appendiceal orifice. And if you don't see the IC valve, you draw a line, and from the center of that concave fold of the appendiceal orifice and move big wheel towards you and move the scope back, you will end up into the IC valve. Same concept I use in this cannulation of the papilla. So it has to draw a line, imaginary line from the orifice all the way to through those folds, center of those folds, and direct that towards where the wall goes. And you have to cut deep with the knife, otherwise you would not be able to get in there. Which direction you want to start from? Here, go up, or you want to go from top down? It's a personal preference. Majority of the time, what I really do is I go from bottom up, unless I see a stone which is kind of impacted, trying to deliver itself. In that case, I might go from top to bottom. So with that, I will come back here to a different type of papilla. Otherwise, specifically asked about the Sharpe papilla and the up and over papilla. So Sharpe papilla is kind of a Chinese dog, have so many folds in that. And even though the papilla, you can see the orifice is somewhere here, orifice is somewhere there. There are so many folds. It's so floppy papilla that it's hard to get hold of these papilla. So even though you can see bile coming out of the papilla, it's just taunting you. That is so hard to get in sometimes. So there are different ways I use. For me personally, if I see a papilla like this, I have a sphincterotome and wire out. But personally, for me, the simple straight cannula works much better to straighten this papilla for me. Other option is you can have a little bit longer wire out of your tome or cannula and just engage that orifice and just have to slowly maneuver that through. So they are not, these are usually the most difficult papillas to cannulate. The next one comes up and over. Up and over means, this is a picture of the diagram of that. So you can see you go up, over, and down. So these are the papilla. When you see a bulge like this on the papilla, a bulge like this, it looks very easy. But this is what happens is when you go in there, your axis is really straight, but a wire or cannula always hits the roof of the papilla. So it never straightens it. If you keep going or keep bowing your sphincterotome, you're not going to be able to get in there. You're going to keep touching the roof of the papilla. So what you need to do is, in those cases, you go up after your wire or cannula goes in. Then either you can move the big wheel away from you, that does flattens it a little bit, and then you pull back on the scope a little bit, and that kind of takes you over the hump. And then you have to push the scope a little bit in, and that straightens that angle for you. It's just like a kind of a S-shaped papilla. And so that's there are 3 different really steps you have to do in up and over papilla. And many times what helps you with that really is putting some contrast in there, because that gives you a really trajectory, give you a pathway which way you need to go. And once you go in there, you are engaged very well. You can inject a little bit, and that would help you with your movements. And sometimes you really have to lean a little bit to the left, or move your small wheel towards you to straighten the papilla. So what I call giving a direction your tech to advance the wire, if your tech is advancing the wire for you. So here, this is one of the examples of that. You can see if I keep going up or keep bowing my sphincterotome, I'm never gonna be able to take that up and over position that, and it's always gonna be keep hitting the roof, and I would not be able to make this hump over to get in to the bile duct. So here, maybe I might have an example video as well. So this is one of those, even though it looks very simple, straightforward, you can see, I'm gonna stop the video here. If you look at this video, you look at the orifice itself, you see this fold, you see that fold, and obviously there's a diverticulum, and you see that fold. I have this imaginary line, imagination. I can see the bile duct is really meeting the duodenal wall somewhere there. So if you look at my sphincterotome, what is the angle, at least to start with, the axis of my cannulation is going straight towards where the papilla or the bile duct meet the duodenal wall. So that is really important, and the only way you're gonna know that when you are able to see the top of the papilla where it meets the duodenal wall. So here, in this case, it looks very simple, straightforward, easily, you can easily cannulate that, but as soon as I inject, I can see a sum, and I get an idea that the contrast goes this way a little bit, and it has to, it's gonna go up and then come down a little bit and then goes in there. It was not the perfect 100% up and over, but it was that was the closest video I have. I think I'll stop here. Don't want to take too much time on that, but happy to take any other questions.
Excellent.
Khalid,
Thank you very much. Sorry.
Thank you, Khalid. There was a question in the chat box. And there have been remarks about that, but I'll just read that out for everybody, because Muhammad is asking, I have a patient who underwent cholecystectomy 6 years ago. Since then, she has pain in the right upper quadrant. MRCP was okay. They've done an ERCP and removed a small, I don't know what small, I assume small stone from the DHC. She has 2 episodes of pancreatitis, idiopathic, within bracket, after the cholecystectomy, but she doesn't have any signs of chronic pancreatitis. We have excluded the other reasons for abdominal pain. Gastroscopy, manometry, impedance, MRI, spine, all have been normal, including EUS later on, and only once in the discussion it says that the LFTs were slightly, ALTSD might have been a little abnormal. The question was what to do with this patient and what this patient might have. She's had 2 attacks of pancreatitis, and I don't understand whether the ERCP was done and whether the sphincterotomy was done and was it adequate or not. So we don't have that information. And what was the pancreatic duct like if it was seen? I assume MRCP was normal, so it was okay. So Khalid, what would you do with such a patient? And then
So,
John, you can come in and then.
This is, I think, these are always not easy patients to deal with, and especially if she did not have a recurrent pancreatitis and just a stone
No,
and
2 episodes.
We have two episodes.
We had 2 episodes of pancreatitis.
yeah. So what I'm saying is like it's two different. If she did not have a recurrent pancreatitis, that would be a different scenario. Having a recurrent pancreatitis, obviously we have a problem. Is the problem really a sphincter itself, or a problem was a stone itself, or there is some other problem which we are not able to pinpoint here? So if it is was a stone, I assume that's taken care of. Other problem happens is like not if it's a sphincter problem, not doing a complete sphincterotomy, could that be a problem as well? And we are gonna assume those two are not the problem. Sphincterotomy has been done completely. There's no stone, so that's not the problem. And
that's right. We have done a sphincterotomy and we have removed a stone with the first episode from pancreatitis. And then she come also to our hospital and have the second episode with the episode of pancreatitis with an elevation of lipase about 2000.
So, yeah, I was going to come to that. So I'm just trying to exclude and then move on to the next step. So it's we assume it's not a stone case. We took care of that. We assume it's a good sphincterotomy done. It's not a sphincter, at least not a biliary sphincter problem. They could have a pancreatic sphincter problem. So that do need to do that step. With the pancreatic sphincter portion, yes, you can do a sphincterotomy on that, but you have to keep in mind it's the biliary sphincterotomy which does not reach the nose. With the pancreatic one, when you do a sphincterotomy, there's always a issue of running into later into scarring of that. But in this particular case, if you have excluded everything else, then maybe next step may be to do a pancreatic sphincterotomy. But these type of patients, really, if they really have a sphincter problem, biliary sphincterotomy, complete biliary sphincterotomy should take care of that sphincter problem. Sphincter problem, we're talking about sphincter of OD dysfunction. So that's a totally separate topic as well. I'll comment a little bit later. Okay. But in these cases, usually it's not straightforward. It's some sort of molecular genetic problem in those patients, which is hard to deal with. And so you have to just keep an eye on that. Unfortunately, there is no other solution to the problem, especially if you have ruled out everything else. And eventually, their pancreas eventually is going to burn out. And before that happens, maybe it's a time to go for islet cell transplantation. But in this particular case, what I would try is maybe do a pancreatic sphincterotomy if everything else has been done, and then see the effect of that. We can talk about SOD a little bit later, but Saad Bhai, anybody else has comments?
Yeah, John, John or whoever, John, yeah. After you, whoever else wants to, and then I'll share what my views are.
Yeah, so I understand this is a patient, sounds like they've got recurrent acute pancreatitis, they've had a sphincterotomy, they've had stones removed, they don't have a gallbladder. You have to start looking wider, don't you? So what medications are they taking? Do they have any genetic causes for pancreatitis?
She doesn't take any. She doesn't take any medication, and we have done the serologic AGI 4 anticore. We have done it, that was normal, and we have done MRCP in 3 episodes, so that was normal. And we have done a lot of examination, and they such as MRT and other. She doesn't have any other cause, and then we think that could be a problem with his sphincter. We have done Erweitert or an expanded sphincterectomy of the gallbladder, and that she has a transit then she get well. She went well, and then after 3 or 4 weeks, she had also this pain. She took to paracetamol, ibuprofen, but not others.
Okay.
Yeah, assumption here is it's a true idiopathic. We have ruled out everything else, includes drugs, medications. Everything has been ruled out.
Did I hear correctly that they have done extended a pancreatic sphincterotomy as well?
Nine. We
No.
did.
Yeah. So yeah, these are tricky, aren't they? So yeah. So just the common bile duct. Yeah, we don't often leap in and do a pancreatic sphincterotomy. I mean, I was uncertain whether this was recurrent acute pancreatitis or recurrent biliary type pain, because they're quite different, aren't they? So if you've got recurrent acute pancreatitis, then there are a number of things like we've talked about that you need to look for. And there's a group of patients, you want to get it down to about 10% of your recurrent acute patients where you just can't find a reason, because you want to, if you can, find something you can intervene on. People have used things like antioxidants with, varying benefit with these kind of things. But yeah, looking at medications, she said she's not on any. If it was just recurrent pain, and I'm sure we'll come to SOD later on. In fact, Nadine put on a really good link to an article actually written by one of my direct colleagues who we work very closely with. We used to do a lot of manometry. We haven't now done it for about 3 or 4 years. The episode study pretty much was the nail in the coffin for particularly type 3s and type 2s. For us, if they have recurrent pain with definite more than 2 times the upper limit of normal ALT rises, then we'll just do a sphincterotomy. Doing manometry doesn't seem to help anymore. The type 1s, I don't think we see many of those because they probably get done because someone thinks they've actually got something in the duct. So they get done anyway. But someone with recurrent acute pancreatitis, as you've described, yeah, it can be very difficult. I guess, as Khalid was saying, these are always hard because if you've got someone who you can't find a reason for why it's coming on, you can't then give them something to prevent that. I mean, like I say, we've tried antioxidants, but the evidence for that's pretty limited. You've done all the other things I could think of. The other thing is, when you say he's not taking any medications, the other thing is to just check they're not buying anything what we call over the counter. So
we have even asked her. She don't take any medication, not over the counter medication.
Okay.
Also herbal
all that stuff. Yeah, no, I mean, in the end, you just can't find it in some people, and you're left with you're getting recurrent pancreatitis, and we don't know why, and you have to manage those episodes. They'll eventually get chronic pancreatitis. It's just whether you decide at what point do you think is it worth considering pancreatectomy for these patients with possible adults.
We have also done an aspiration of the from the gallon duct, and we make a biopsy, and we don't take to also pathology, and she found any only chronic inflammation.
Yeah. So, I mean, there was a great study from, I think it was, what's his name, who's one of the editors of Mel Wilcox and their group from in the American Journal not long ago, looking at the difference in quality of life in people with recurrent acute pancreatitis versus chronic, and it's virtually the same in that people with recurrent acute pancreatitis actually don't really get back to normal in between. So as they progress through this, you get to the point of thinking, well, we should start to treat them a bit more like a chronic. I.e., do we need to think about some other intervention? Is there a role in some of these people, particularly if they're young and fit, for removing their pancreas and giving them islets? But you'd want to be able to do it as an islet cell transplant program.
And John, one of the key take-home messages, I think, which we all should bear in mind is we should not let these patients get to a stage where they become dependent on the opioid analgesic.
Oh, hell yeah.
There's a very small group of patients where you are able to offer an endoscopic intervention. And the key message is, if you are able to offer it early on. Don't let them linger on for months and months and become dependent on the opioids. And that's something we see a lot in our practice in my pancreas clinic. Majority of the patients, by the time they get referred, they're very well established on opioids, and it's far too late for me to offer them any endoscopic intervention. And that is a message I keep on sort of sending out as best as I can.
Sorry, Nadeem and John, did I understand correctly? So we still have the pancreatic duct and pancreatic sphincter intact, and is there a suggestion of doing anything, or is everybody saying that we shouldn't do anything about it?
I think it depends on what the anatomy looks like. So if you've got an up-to-date MRE-US, if there's a stricture, then that might be worth putting a stent in. But if it just looks, irregular, or isn't particularly dilated, there's no
I-
signs of
I
pressure.
can-
There's not a lot of benefit, is there?
Well, we have a reasonably large practice of patients with pancreatic issues, and I can remember at least 3 patients where we have had similar kind of situation, and we've gone in and done pancreatic sphincterotomy, and 2 of those patients have actually not had any further attacks, and we're talking about pretty reasonable time. My question here is that while we are talking about this actually eventually burning the pancreas out and all the risks that are going to come with it, or islet cell transplantation. To me, pancreatic sphincterotomy again is when we started doing ERCPs, it was a no-go area, and this is something that in our unit we do about, I think, at least 8 pancreatic ERCPs a week, if not more. And we tend to do them, and obviously with the stents and everything else, it's completely changed from the time when I started doing ERCPs 30 years ago to what we do now. And I personally, maybe I'm the odd one out here, but I would certainly give this patient a trial of a pancreatic sphincterotomy with a pancreatic stent for some time and see how he responds or she responds. If they don't have a response, I don't think we would lose much in a patient where we have really no real option to offer at this moment in time. But that's mainly because she's had 2 attacks of pancreatitis. I agree totally. If this was without pancreatitis, then I wouldn't bother doing anything at all. But with pancreatitis, I think I would be very, very seriously considering going into the pancreatic duct, even if they don't have a stricture, because I think the same thing would apply as it would to the bile duct. And again, I feel that in the long term, Khalid just mentioned that the risk of stenosis is more. I think the risk of stenosis in pancreatic duct against sphincterotomy, Khalid, you may agree with me, is that initially when we were doing pancreatic sphincterotomies, it was the same thing that was being done very early on in ERCPs when we were doing biliary sphincterotomies. We were not actually adequately cutting the sphincter. And if you do that, maybe, we will find out that pancreatic sphincterotomy again doesn't, it probably is not as bad long term as we probably see it now. But that's just my feeling. I may be totally wrong.
No, you're absolutely right. Whenever we do a biliary sphincterotomy, I like to see the split of the muscle. And same thing with the pancreas. What I really like to see is I want to see the whole wall of the orifice. I want to see the duct itself from inside, and that is the adequate pancreatic sphincterotomy. So that's what I was mentioning. If like we have ruled out everything else, as Saad Bhai said, if we ruled out everything else, no stones, biliary sphincterotomy performed, the only option really left is do a pancreatic sphincterotomy and do an adequate pancreatic sphincterotomy.
If I'm just going to take this a bit further, if I may, and I think the point that Dr. Saad Niaz have made is very relevant and important. And that is because if you look at the pain, why these patients are getting pain, there are 2 major reasons, and that's mostly seen in patients with chronic pancreatitis. But I think this is a group of patients which will eventually develop one if they have not already developed it. And that is the ductal hypertension phenomenon. And the ductal hypertension can only be treated if you either do a pancreatic sphincterotomy or leave a stent in to allow adequate drainage of the duct. And if you can ensure this, then there is a reasonable success rate of preventing further attack of pancreatitis. If they developed a parenchymal injury and then atrophy and the ischemic injury in the pancreatic parenchyma, that is again a stage when no matter whatever intervention you offer them, you will not have much success in that patient group. So again, the same message, if you have to intervene early.
And with regard to, you have to be careful about the pancreatic stenting as well. So these patients, if they have a normal duct and normal parenchyma, you don't want to leave the stent in there for too long as well, because the stent itself can cause ductal changes as well. And with regard to pancreatic stent, just remember that pancreatic neck is the watershed area of the pancreas. And so that's the area which is more prone to injury and ischemia. And that's why we patients with this pancreatic necrosis and these pancreatitis changes, majority of the time, that's the area that gets involved. What I'm trying to get at is, please, when you put a stent in there, the stent should not be ending at the neck of the pancreas where it's taking a turn, and either it has to be long enough to end towards the end of the pancreas, or it should be short enough that it's not ending at the neck of the pancreas, but it should not be a long-term stenting and leave the stent there forever. Stent has to be there for a few weeks. I'm not talking about the strictures. I'm not talking about the chronic pancreatitis. I'm talking about the normal pancreas parenchyma one. So those, you cannot leave the stent in for more than 4 weeks or 6 weeks. Otherwise, there are going to be stent-related changes to the duct.
Okay, thanks a lot.
Khalid?
Yes.
We were unfortunately today, because of Dr. Reddy's commitment, urgent commitment, we missed out on the talk. Unless there are any burning questions, I was just wondering whether we should continue or call it a day now.
I'm just wondering, sir, if I could ask a supplementary question to Khalid. Khalid, do you remember Marty Freeman presenting his talk where he mentioned the stent that he uses, which is a 3 French stent, which is quite long, goes through the bend, through the neck of the pancreas and into the main pancreatic duct. Whereas most commonly used stent, at least in our unit, is the 5 centimeter, single pigtail. So what do you prefer? Because if you are using a stent to go over the bend, which is soft and smaller French, it may be less of a hazard to cause future injury or stricture.
So for me, the simple solution to that is, yes, I have used many 3 French stents, but that is not my to-go stent anymore, because for that, you really need a smaller wire, which is 018. It would not go over the bigger wire, any wire which is bigger than that. So there is a 4 French stent. So 5 French stent for me is a way too big, unless there is an AMSA loop and I know I'm not going to be able to cross the neck of the pancreas easily. In those cases, I may use a 5 French stent, but 3 centimeter or so, and I always take the flange off that. I'm talking about normal duct, just for post-ERCP pancreatitis prophylaxis, where I want to leave the stent in for only few days to few weeks. That's the only, what I'm saying is applies to that. So in those cases, I take the flange off if I'm going to use a 5 French and shorter stent, which would be 3 to 4 centimeter. But for me, majority of the time, I use 025 wire, and I use 4 French single pigtail stent without internal flange. I will use 8 to, they come in sizes 4 French by 8, 4 French by 10, 4 French by 12 as well. So those are the ones I would use, and they cross the neck of the pancreas. So instead of 5, instead of 3, my to-go stent nowadays for the last few years is 4 French for these kind of cases. 4 French by 8 or by 10 centimeter. Single pigtail, no internal flange.
Thank you. That's excellent. Saad, there is a question from Dr. Tran regarding prevention of bleeding after sphincterotomy. So in the question section, so I guess any of the panelists could answer it.
So go ahead, John.
Yeah, I thought it was an interesting question. I'm not sure how easy it is to prevent bleeding. I guess it's about a 1% risk at sphincterotomy. Just that's what it is. The main thing is to make sure you've done all the pre-things first. So make sure that if they're a sick patient, clotting platelets and everything's fine, that they're clearly off any anticoagulants, particularly antiplatelet agents, and that your diathermy settings are set to the recommended ones, if you like. So with a bit of coag, without, if you get bleeding, there's a whole load of different ways you can treat bleeding, but prevention, I think, is a slightly more complicated issue. I don't know if you have any other thoughts about that.
So,
John, once, sorry, just one comment. Peter Cotton once mentioning that you've if you inject adrenaline 1 centimeter above the apex of the sphincterotomy, then it is most likely to stop bleeding because the arterial supply is from above downwards.
So bleeding always happens at the upper end. So it's never going to be from the sides. It's always at the apex of the sphincterotomy. So usually when you do a sphincterotomy, I look at the papilla. If it is right at the edge of the diverticulum, inside the diverticulum, close to the diverticulum, those are the one which bleed. The other ones may bleed here and there, but those are at low risk. So for the papilla, which is close to the diverticulum, I am more careful in those. So bleeding is, I think either Sadbhai says or somebody said, like bleeding is only a cut away. So it's gonna be, and you don't know what cut is that, what step, and so I would be just really careful, more careful in periampullary, in cases where there are a periampullary diverticula, and otherwise really no way to predict which is going to bleed or not. And my first to go, if the bleeding happens, the first thing is really not to panic about that. Don't lose the wire. Get a balloon into the duct, the extraction balloon, hyperinflate, pull it back where it is putting a pressure at the apex, big wheel towards you, hyperinflated balloon, bringing it back, just put a pressure there, take few breaths, stand there for a couple of minutes. Even if it doesn't stop, at least it will slow it down. So the only I can predict which is going to bleed more is when there is a periampullary diverticulum. Otherwise, it's not possible to predict which ampulla is going to bleed.
But I think the other thing, like you're saying, Khalid, is to have the things ready, isn't it? So, you know, whenever you're doing an ERCP, you know you're going to do a sphincterotomy, that you know there's adrenaline available, that the other things that you might wish to have are available relatively quickly. And like you say, they always say around here that the first pulse to take in an emergency is your own.
I think it's almost an hour. And
yeah, Khalid,
GG.
you can wrap it up.
Yeah, I think
with you.
So I think these are good discussion points, and we were able to take advantage of this free hour. And I just I wish Eid Mubarak to everybody, those who are celebrating. And it was nice to talk to everybody and see everybody till next Sunday, I guess.
Yeah.
Thank you, Khalid.
Thank you, everybody. It remains for me to thank everyone. And, you know, we wish Eid Mubarak to everyone, as Khalid said. We're hoping I'll get connected with Dr. Reddy and see if he's available next Sunday. So we might have the same talk next Sunday, but you will get the info as you normally get. Thank you very much. And I apologize for this session's you know, slight issue that we had, which was beyond our control. So all the best. Enjoy the remaining day off. Take care.
Yeah. Eid Mubarak.